Welcome to our video on osteomyelitis. Let's get started. Here's our overview slide. We'll be discussing the definition, classification, risk factors, clinical features, diagnosis, and management. Let's begin with the definition. Osteomyelitis is an infection of the bone and marrow. It's most commonly caused by Staph aureus. Osteomyelitis can be classified into hematogenous and non-hematogenous. In hematogenous osteomyelitis, the pathogen from metaphyseal vessels deposits in the metaphysis of long bones. This most commonly affects children and IV drug users. In non-hematogenous osteomyelitis, the pathogen directly spreads from a contagious site such as cellulitis or is directly inoculated into the bone, for example during trauma or surgery. This most commonly affects adults. There are multiple risk factors, including sickle cell disease, commonly associated with salmonella, IV drug use, prosthetic joints, which are commonly infected by coagulase-negative staphylococci, diabetic foot ulcers, and open fractures. All right, let's move on to clinical features. A patient with osteomyelitis typically presents with pain, swelling, erythema, and tenderness over an involved area. Fever and chills may be present, and a draining sinus tract may also be found in chronic conditions. All right, let's try a question. A 65-year-old man presents to the office complaining of moderate pain and swelling over the left hip region. The pain started 2 weeks ago and gradually increased in intensity. There is no fever. The medical history is notable for prior left hip joint replacement last year. Physical examination of the involved area reveals a sinus tract. What is the most likely cause of these findings? All right, so we have an elderly patient with a history of hip joint replacement who presents with pain and swelling over the hip region. A sinus tract is detected on physical examination. These findings strongly suggest osteomyelitis secondary to a prosthetic joint infection. The infection is chronic since it occurred after more than 6 weeks from the date of the hip replacement. And we know that the most common cause of osteomyelitis following a hip joint replacement is coagulase-negative staphylococci, particularly Staphylococcus epidermidis. Now let's discuss the diagnosis and management using this algorithm. When osteomyelitis is suspected, for example, a patient who presents with pain, erythema, swelling, or a draining sinus tract, the initial evaluation should include inflammatory markers, obtaining blood cultures, as well as radiographic imaging. A white blood cell count may be normal or elevated. ESR and CRP are also usually elevated, and these are sensitive findings but non-specific. Blood cultures are typically obtained and they can be positive in about half of cases of acute osteomyelitis. A plain X-ray is appropriate if the patient has had symptoms for more than 2 weeks. However, if the patient has had symptoms for less than 2 weeks, an MRI is the imaging of choice. Typical findings are bone marrow edema and periosteal elevation. If there is a contraindication to an MRI, such as the presence of metal hardware, then nuclear imaging is an alternative choice. To confirm the diagnosis, bone biopsy can be done as this test is the most accurate diagnostic method of osteomyelitis. Culture should also be obtained before initiating empiric antibiotic therapy to identify the causative pathogen. However, let's note here that if findings on radiographic imaging are characteristic of osteomyelitis and blood cultures are positive for a likely pathogen, then a bone biopsy may not be needed to confirm the diagnosis. The next step is initiating empiric therapy as well as surgical debridement. Surgical debridement is essential in cases of bone marrow necrosis and pus collection. Empiric therapy includes antibiotics effective against methicillin-resistant Staph aureus and gram-negative organisms. Therefore, vancomycin plus a third or fourth generation cephalosporin are usually given. Definitive antimicrobial therapy should be provided when the results of cultures and sensitivity are available. This is an MRI of the spine that shows significant intensity changes of the L3 and L4 in a patient with vertebral osteomyelitis. We can also see narrowing of the intervertebral space and destruction of the intervertebral discs. All right, let's wrap up with another question. A 50-year-old male with a history of a recent case of cellulitis of the leg presents with a fever and increasing low back pain that began approximately 1 week ago. There is tenderness to percussion over the lumbar spine. ESR and CRP are elevated, but X-ray of the lumbar spine reveals no significant findings. What is the best next step in the management of this patient? All right, we have an elderly patient with a fever, increasing low back pain, and tenderness to percussion. The history is prominent for recent cellulitis, and the ESR and CRP are elevated. The combination of these findings raises suspicion of vertebral osteomyelitis, likely due to hematogenous spread of pathogens from the recent soft tissue infection. X-ray of the lumbar spine is normal, and that is expected because we know that findings of osteomyelitis on a plain X-ray cannot usually be detected in the first 2 weeks of an infection. So the next best step in the management of this patient is an MRI of the spine. And that concludes our section on osteomyelitis.